Hi, everybody. Welcome back. We have our next presenter for today, Dr. Joella, and I am very happy to introduce her. She has a very unique combination of skills and experience and degrees to her credit. And she has been working in the field of childbirth for about 20 years now. She's a chiropractic doctor, so she has a very deep understanding of how the human body works, with a special focus on the female pelvis. And she has cared for over 1,000 pregnant women and babies. Not just as a chiropractor, but also as a midwife. And I think this unique combination really makes her skills very special because she can help with asynclitic presentations, shoulder dystocia, posterior presentations, and her special focus is on protecting newborn neurophysiology and also avoiding unnecessary trauma. She lives in the USA, and she's looking forward to jump into teaching, and looking forward to your presentation, Joella. Very happy to have you here. She's going to be talking about bodywork in labor and birth from a chiropractic and a midwifery perspective. Thank you.
Okay, thank you so much for that introduction, Chaitna. As Chaitna said, I'm Dr. Joella. I've been a chiropractor for about 19 years, and I've been practicing midwifery for about 13 years. I am going to talk about just supporting function in pregnancy. It's about function of the female pelvis and how we can optimize the birth process by doing so. I'm going to talk a lot about physiology, specifically from a chiropractic perspective, and how incorporating body workers into your team is helpful for you as the midwife and all for all of your clients. I was introduced to physiological birth and midwifery care when I was in graduate school. So for chiropractic, it is a graduate program similar to medical school in the United States. And about a year into my schooling, I was introduced to specializing in pregnancy and pediatric care. And it just really called to me right away. Our first module that I did on top of my schooling was specifically for pregnancy care. And I have to say, I walked away from it feeling quite traumatized, because I realized that I was a married woman of childbearing age, and I knew absolutely nothing about pregnancy or how everything worked and what the system kind of encouraged in the challenges. I also suffered spinal fractures as a teenage elite gymnast. And so back pain was something that I was very commonly used to. It's what got me into chiropractic in the first place. So I was always pretty flippant about childbirth and saying, oh, I will for sure get the epidural. I've had enough back pain in my life. I don't need to experience that in my labor as well. And then I went to this module and I understood the physiological process and all of the things that are supportive of it and all the things that hinder it. And I walked away just feeling like, how is it that nobody knows this? We don't talk about these things. And it really just kind of lit a fire under me that I wanted to be one of those people that worked with this, that helped women have better experiences, better outcomes, and particularly to help avoid unnecessary trauma to them and to their baby. So I had my first baby with midwives at home just a couple of days after I finished chiropractic school, and immediately went in and started my own practice. And from the very beginning, I specialized in pregnancy. I worked really closely with the midwives in my area, which means I saw a lot of their clients and helped them. Many of the midwives in that area at that time were pretty well versed in chiropractic and knew that it was helpful. And so when I came around, they were super excited. And so especially people who had difficult previous deliveries, people who were attempting VBACs, they highly encourage that they seek care to have better chances of a really good outcome. For the first 7 years of my practice, I just took care of a lot of pregnant women and children. And occasionally I would get called to births from midwives when labor was stalled, or when baby was clearly in a bad position and we just weren't getting anywhere. If there was something else odd that was going on and we were trying to figure out what was going on, they would call me in. I was super happy in that role as a chiropractor to show up, kind of assess what I could do, work with the mom. And then as I see labor start progressing, I would leave, and I was fine with that. I had no intention of becoming a midwife. It was not a liability that I cared for. I have no desire to go back to school. And then again, about 7 years into practice, I got called to a birth. And in early labor, the mother fell really hard onto her pelvis, and contractions went from very easy and manageable to very excruciating and really not doing anything. I was able to facilitate changes, baby turned around, she went back, stood up, contractions started again, and suddenly she was about to have a baby and her midwife and assistant were not there. So I walked away from that having to face the decision of what I was going to do about this. I really wanted to be able to support people in labor, but it was also really illegal for me as a chiropractor to be in that situation. And long story short, I eventually came to the conclusion that it was just time for me to go ahead and go to midwifery school and get this also. I didn't really know how I was going to practice, but it felt like a requirement liability wise that I was going to have. In my midwifery practice now, as I've been practicing, I really combine both disciplines. I have a very busy chiropractic practice where I take care of clients with really all of the providers in the area, all of the midwives, all of the obstetricians, as well as the midwives in the hospital. And then I have my small midwifery practice where I see people both as a chiropractor and through all of their medical prenatal care and deliveries from the beginning of their care all the way through postpartum. The combination of these two over all of my years of experience have allowed me to really make connections, to analyze the pelvis a little bit differently, make those connections of what's happening, what I'm assessing and working with as a chiropractor, and how that's translating to what's happening during birth. And most importantly, I was able to start making those connections of what we were missing, those areas that actually needed to be prioritized, because chiropractic, just like every other healthcare discipline, the prioritization of what we work on and what we see as normal is really more based on the male body. And so I was able to start making these connections that there were areas that we were kind of avoiding, unless it was really extreme symptoms with somebody or an extreme trauma had happened. We were avoiding certain areas, and then we weren't prioritizing the right thing. So we were making some really great changes. Obviously, people were still getting really great results. But when I put those things together, I started seeing really dramatic changes in my practice. And that was about 10 years into my practice. So about half my practice was prior to some of these initial or these additional changes. And then the last half, it's been quite dramatic. And really the goal is that we're trying to just really optimize the neuro-biomechanical function, particularly of the pelvis, because that's what really affects the childbirth process, but really has impact on the childbirth experience as well. We're talking about humanistic care, and that experience is so important. And then the added bonus, of course, is that we're avoiding a lot of unnecessary trauma. So the birth statistics in my practice, I have always kept very stringent statistics in my office. And that's mostly because I have an analytical mind. I'm a bit of a perfectionist, and I really wanted to be clear that what I was saying was actually happening. And so I have kept statistics on every pregnant person I've taken care of as a chiropractor, which is about 1,300 now. And then I take more specific statistics in my midwifery practice. For my midwifery practice specifically is what I'm going over now. These are people who have been under chiropractic care with me from the very, very beginning of their pregnancy and continue through 6 weeks postpartum. For those who start labor with me, there's a 93% success rate that they are going to continue at home with a vaginal delivery. The small percentage of transfers, the majority still have a vaginal birth. VBAC, success rate in my practice is about 90%. And I do have about 30% of my practice has maintained for VBACs. That's just, I'm one of the providers in the area that has always taken care of VBAC clients, and that has the options for that has kind of waxed and waned over the years in my practice in my area. So I have always kind of seen quite a bit of VBAC clients, and they're usually directed to me also because they get the understanding of things did not go well the first time, and now they're going to do everything they can for a better success rate. And chiropractic is part of that. And so they just combine the two with me. In my chiropractic statistics, so this is with people who come to care for me, they're in my statistics if I saw them just 3 times. Most people are referred to me in the 3rd trimester, though some present early in pregnancy or midway through. And so the amount of care really can be all over the place with those numbers, and who they are seeing and the type of birth supportive care that they're receiving are completely different among all of that population. And the success rates for VBACs is still 88%. Clearly, those are good signs that we're making big changes and making more positive birth outcomes just by supporting the body in pregnancy in childbirth preparation. And here's where in my midwifery practice, things stand out quite significantly. And this is the things that I have seen change as I have changed some of my prioritization in my care for chiropractic. The average active labor in my practice is about 3.5 hours. If I calculate primiparous mothers only, it's about 5.5 hours. This is obviously really different than the standard of what research shows us. And many people want to kind of slough this off and be like, well, you see different types of people. But I see people with a lot of really complicated histories. I do see homogenous in the case that most are middle class and white, but they come from very different lifestyles. They have very different belief systems, and many of them come to me in a little bit of higher risk because of difficult previous circumstances. And so what I hope to convey in this conference here is that when we're talking about function and when we're optimizing function, we really have a dramatic impact, not only on how a woman feels and experiences pregnancy and birth, but how that birth really, the process undergoes, how much more efficient it is and how much less traumatic it is. The primary cesarean rate in my practice is about 4.5%. So you can see from that home delivery rate, the vast majority stay at home and deliver without complications, a small percentage transfer, and most of them still do have vaginal deliveries as well. Now, I will give one caveat that's really important, especially for you hospital providers. Obviously, I am working with healthy mothers as a home birth provider. Some of them do have complicated histories and are considered high risk in some level, but medically, they are healthy people. They do not have other physiological issues going on that are complicating their pregnancies and deliveries. The number one goal that I want you to realize here is that chiropractic plus supported physiological birth just gives us better pregnancy experiences and better birth outcomes. As I said earlier, this is about the humanistic care, which is all about the experience. What is the client desiring? What are they feeling? What is chosen because of their beliefs and their circumstances? All too often, we are not paying attention to these things. What women are feeling often is being dismissed. Oh, it's normal. You're going to have to just deal with this. What you want, well, that's great, but this isn't going to work. This is really about combining all of this information and giving us the ability to give more options to our clients, let them take proactive choices for their care and do the things that we can do to support it further. So the goals for this is to have a better understanding in the function of pregnancy, particularly of how the female pelvis works. This one I'm going to repeat over and over. Suffering in pregnancy is not necessary. We were able to have a small skills workshop recently here in India. And one of the big takeaways that I had with an obstetrician is this, that women do not have to suffer just because they're pregnant. This has become a really common thing that we've just assumed and we've carried on without really good reasons. When women show up and they have a complaint of something, that's a sign right then and there that something's not working properly. I'm going to go into all of these things in detail, but I really want the message to come through that just because they're pregnant doesn't mean they have to experience all of these unpleasant things. Symptoms are just normal because they're really not. Supporting better function in pregnancy does equal better birth outcomes. And the most important thing also as midwives is that you can't provide all of the care. There are things that we need to collaborate with others to give supportive care. It's not our job to take care of every single need of our client. So when we can learn more and identify things, then we can gather a team and we can work collaboratively, which is so much more helpful. So I'm going to talk about some common beliefs. All too often people come to me and they'll say, well, I don't really have any complaints. I mean, there's just some things, but that's normal pregnancy stuff. So I don't really need to talk about that. And I stop them and say, okay, tell me what these normal pregnancy complaints are. And it's low back pain, it's SI pain, it's pubic symphysis pain, it's sciatica. All too often we're told that just because you're carrying more weight and because you're pregnant, these are just normal things that you have to experience. And that's not true. Postpartum dysrexia and pelvic floor weakness are also not because people had babies the vast majority of the time. What I really want to take away once we start going through the physiology is that this is all related to how the body is functioning. And these are all signs that the body has not been functioning well. And most often it's because of how a person is carrying, holding, and moving their body on a daily basis that's causing all of these things. And these are things that specialists like I can help with, but also every provider can be aware of and make advice and recommendations that help them and take away most of these symptoms completely. It's very common in my practice for people to feel better when they show up in my practice in the third trimester than they did in the second trimester. And they wonder, why didn't anybody tell me to do this earlier? None of these are normal effects of pregnancy, but instead, every single one of them are signs of dysfunction. Restoring this function corrects it, and the vast majority of the time, the pain just goes away. So why do we have these myths? In the health field, I think one of our biggest challenges is that we are very often misunderstanding the difference between what's common and what's normal. There's normal function. This is how things should be when it's working properly. And then this is what many people experience. Those are not the same thing. So just because a lot of women have back pain in pregnancy does not mean that it's normal. Does not mean that it's expected, does not mean that it's necessary. Also, in the standard medical, primary care providers don't have a whole lot that they can do about this. The standard medical treatment for pain is analgesics, which we know we try to avoid as much as possible in pregnancy. And so most often, and as I was talking about in this recent workshop, but talking with this obstetrician, she said, there's nothing that I can do. So I just kind of say, well, that's just how it is, keep going. And I just kind of don't address it. But I'm here to say that there is things that we can do to address it. And this is where, again, it doesn't matter if you have the tool, it's a matter about offering information and providing referrals as necessary. And then lastly, we really focus a lot on symptoms and not on function. And this is really important when it comes to identifying abnormalities that are true pathologies. This is very important in our risk assessment. But then we have this very large kind of category that we all considered normal, and dysfunction is part of that normal, even though it's not. We have functional and we have dysfunctional. Those tend to fit in this category that we call normal. And then we have the abnormal and pathological that needs to be diagnosed and treated appropriately. So this box of normal is what I want to change. I want us to understand that it's not all normal. There's functional and there's dysfunctional. We have the capacity to work in those boxes, regardless of the degree of our scope, unlike the pathological areas, but it's not normal. We can do that. So we're going to get into chiropractic and some physiology about the female pelvis. Chiropractic is the science and practice of increasing the communication between the brain and the body by restoring proper function of the spine and pelvic joints. This might be a slightly different definition than you would have considered understanding previously. And we're going to get into the specifics of that. The biomechanics has been pretty well understood. Most people are pretty okay with understanding and accepting this reality. The muscles and the joints of the spine and pelvis need to function properly for us to feel better. The movement is important. The balance of those joints and muscles is important. And then through chiropractic, we're decreasing that muscle tension, scar tissue adhesions, and decreasing inflammation. So this is our standard idea of chiropractic and how it helps with pain and movement. However, we also know that the brain and body communication happens through the nervous system, which correlates directly with the function of the spine and pelvis. The leading neuroscience research right now has finally caught up to us. The technology has finally caught up so that we can research this properly. And what we are seeing is that a chiropractic adjustment, different than a gross mobilization, I need to make that clear, when it's assessed and we know how to apply a specific force to an area that is restricted, we get an instantaneous, dramatic stimulation to the prefrontal cortex. The prefrontal cortex of the brain is one of our biggest areas that tells us pain. And the key is that it tells us pain sometimes even without tissue injury. So we haven't had a trauma, we don't have inflammation, we don't have any type of acute issues happening, and yet we'll feel pain. The prefrontal cortex needs to know what's happening with the body on a regular basis. It needs movement to tell it what's going on. And so when messages are not happening to that prefrontal cortex clearly, maybe they're diminished, maybe they're not happening at all, maybe it's sending messages showing that something is just not working quite right, then pain is an often signal that the brain creates to tell us that something's going on. This is what's happening when people come in and they say, I have all of this pain, they get adjusted and they instantaneously say, I feel better. It's not that we did some huge dramatic treatment to this one area. It's that we mobilized the joint, it sent proper communication to the brain, and the brain said, oh, everything's fine, and turned off that signal. That is happening in a portion of the people coming to us for pain. The other portion actually does have local tissue injury and balance and tension issues that we're working through also. So more on the neurological component. If you just focus on the orange boxes here, what you want to see is that on the left side there, we see appropriate joint movement. This is when a spinal joint is moving well, really any joint, but spinal joints just have significantly higher amounts of mechanoreceptors, which is the nerve cells that tell our body what's going on. So when there's appropriate joint movement, then it sends signals. The afferent input is that sensory input that goes up the spinal cord, goes to the somatosensory processing area of the brain, gets processed and integrated in the brain, which is crossing it over the brain to the other side to then stimulate motor control. That then goes down, tells the body how to function properly, which is this balancing of tone. It's allowing muscles to relax. It's allowing muscles to contract according to what the body actually needs in that moment. So it's allowing that motor control to function well, which then encourages good joint movement to continue. When a joint is restricted, this is chiropractor's job. The spinal manipulation, the spinal adjustment, increases that joint movement where it's not, where it's restricted and not getting good input to the brain, which then mechanically increases that input, stimulates the prefrontal cortex, stimulates the somatosensory system, that processing continues, and we get better function. If we aren't getting appropriate movement, we aren't getting adequate neurological communication. This results not only in pain, but then decreased motor output, which means tone and the ability to contract will be impacted. What we see is that this makes a really dramatic change in our muscle spindle response. I would love to go through the research because it's super fascinating, but I have kind of limited time with you guys today. But what I really want you to understand, one example of this is that there was a new study in New Zealand, and it was done specifically on pelvic floor function in pregnant women. Now, it's important to note, these women were just pregnant. They were not coming to be treated with a certain type of symptom. They were pregnant, and so they were put in this research study. What they did was they measured the pelvic floor function before the adjustment and after the adjustment. And they found that after the pregnant women were adjusted, the pelvic floor muscles appeared to relax more when they were at rest. If you were a part of yesterday's conference, you'll know that rigidity, hypertonicity of the pelvic floor muscles is a really common problem that we need to address. So how important is this to allow that prefrontal cortex and motor control to tell those muscle spindles to relax when the body is supposed to be at rest? Can you think of why this is so important in childbirth? The research shows or suggests that there is a 25 to 30% reduction in labor time with pregnant women who are seeking chiropractic care. From my statistics, I think that it can be even significantly higher. And this is why. The muscles need to be able to respond to the pressure of the baby and relax and allow the baby to move through. And chiropractic adjustments scientifically show a difference in how that's functioning. So let's look specifically at these muscles. Again, I really had hoped to go through a little bit more specifically the different muscles and the different orientation and what things react to it specifically, but we just don't have enough time. So I just want to take a picture on the right. These are the posterior pelvis muscles. You see the sacrum in the middle, and you see where the ligaments are is the SI joint. You see the glute muscles and the piriformis muscles. You also see that sciatic nerve. Imagine if those muscles are hypertonic, if they're restricted, if they are guarded, what is going to happen? They're going to irritate that sciatic nerve. They're going to affect the motion of the SI joint. This is all going to cause increased pain, but also this distortion on the outside. Now, being a chiropractor and a midwife, I could see that certain patterns of this type of distortion biomechanically on the outside was translating internally to how the pelvic floor was functioning as well. So if we look on the image on the left, you see the psoas muscles, these strap muscles coming down from the abdomen that cross over the pelvis, the large iliacus muscles on the sides that line the inside of our pelvis, and then of course the pelvic floor muscles. If you're looking at this, picture one side of those muscles more contracted than the other side, distorted with a torsional force because of how all of them connect. When they increase tension, they create a torsion if it's only happening on one side. So if you picture that, how is that going to impact a baby's position entering the pelvis? How is it going to impact the baby's ability to go through the cardinal movements of labor? It's going to impact it significantly. This is why when there's balance in these muscles and they can relax and respond appropriately to different forces, babies can move through more efficiently. Okay, beyond the muscles, the ligaments are often ignored. Ligaments are not as dynamic as muscles. They don't contract and stretch readily. They're supposed to be the last-ditch effort to hold things together, particularly two different bones or an organ to a bone. The picture on the right, you can see we have the sacrospinous ligaments, the uterosacral ligament, or not the utero, but the sacrotuberous ligament. Next, you're going to see the uterosacral ligament in the next slide. So the challenges with ligaments is if there has been chronic distortion, if there's been imbalance for a long period of time, then the ligaments are going to also be affected because ligaments over time and undue pressures on them undergo something called creep, which means that they slowly deform. So now we have actual structure that has slowly deformed to hold this distortion pattern. That's going to require more care. It's not going to be just immediate changes with the brain and the local tissues to respond differently and then balance is restored. This is going to require more ongoing care to slowly allow these ligaments to heal and create more balance in the body. You can see on the picture on the left, the back of the pelvis, the back of the sacrum is entirely covered with ligaments. The underside internally is also covered with ligaments. These connect the sacrum to the ilium bones. These connect the sacrum. Internally, they connect the hips together to the pelvis. All of these impact things quite a bit. And the significance also is just to kind of keep this in the back of your mind, because we're going to go over posture soon. And when biomechanics and posture are not functional, they put more pressure on all of the ligaments instead of the muscles, which are designed to support us. So just kind of keep these images in your head. Also on the picture on the right, at the top, you can see the psoas fascia. The fascia is also another form of connective tissue. It's like a thin skin that wraps around everything. It wraps around every muscle, it wraps around every bone, every organ. It's a matrix that just combines everything in the body. This is also seems to be an area that really holds tissue memory. So when a distortion pattern has been really long-standing, we can work on muscles, we can adjust vertebra, we can adjust pelvic bones. And then sometimes we get this balance and then the patient kind of stands up and starts moving around and that fascia just wants to wind right back up. Sometimes this really has to be released as well. And there's a number of different forms of body work that work with it. But really it's about, this tells you if fascia is affected, it tells you that this has been a really long-standing problem that has been rooted deep in the body, and the fascia is holding on to this tension pattern as well. And speaking of fascia, here's fascia that we really don't even talk about. We can see here, you see the cervix there, the large connective tissue coming from behind that is the uterosacral ligament. We do talk about that. This is a significant source of discomfort in pregnant people, and I will talk about that more when we get into posture. But you also see this ATFP. I want you to pay attention to look at everything that it's connecting to. It's connecting to the cervix, the vagina, the urethra. It's connecting outwards to the iliac spines. It's connecting all along the ischium, underneath the ischial tuberosities and down, as well as up to the pubic bone. If there is long-standing torsion in the pelvis, imagine what this fascia is doing to all of these canals. Imagine what kind of restriction and challenge this is going to make in the pelvis, creating more balance and allowing a baby to move through it. These are the types of things that we're trying to work on. This is where function is really truly crucial. If all of this is happening, it's going to be a lot more work to help a baby move through this, to allow for the female pelvis to allow that to happen. But when we can balance this and create more movement and flexibility and function, it's just so much more efficient. Okay. So that's a lot of physiology going through their anatomy, but I want to get to some of the things that you can assess. The first thing that a midwife can do is take a thorough history, because we need to identify who has higher chances of needing more care in order to make important changes in preparation for childbirth. History taking is our number one tool that we have that starts on the very first visit. These are the first things that are going to show up if we ask the right questions. Do they have pain or significant issues with menses, primarily, especially a really long cycle, a long period? This usually correlates with a uterus that's tipped one direction or another, and a uterus tipped, again, because of all those connections with the connective tissue and the muscle and the pelvic bones, the distortion, the uterus tipping is the sign that the pelvis is distorted. Okay, so a significant pain and cramping or really long periods is a sign that you get right then that there's something going on with their pelvis. That's very likely. Major injuries, particularly lower leg or leg injuries, lower limb injuries, that's going to affect their gait and their posture, which is going to you'll see in a moment why that's going to impact the pelvis a lot more, and especially the pelvic floor. But also something that's really crucial that we should be asking is, have they had coccyx injuries? Have they fallen really hard on a tailbone and not been able to sit for days or weeks? So often this happens and it's ignored. It's said, oh, you bruised your tailbone, which is not a physiological thing. That's not how this works. That's not how the body works. But we say you bruised your tailbone, it's going to be sore for a number of days and then it will be fine. The female pelvis makes the coccyx really susceptible to injury. If you fall straight on it, you're going to hit your coccyx. That can knock that to the side, that can knock that forward, that can rotate that. And as you just saw in some of those pictures, a lot of connective tissue and muscles, all of the pelvic floor muscles and a lot of the ligaments in the pelvis attached to the coccyx. If that is displaced, you're going to create torsion in the pelvis. So when women have had this in their history, that's a good sign that that needs to be checked and that the pelvis has been affected by that. All too often we ignore it. If I had time to really go into the birth process more, I could do a whole class just on the coccyx and how that is impacted, the signs and symptoms in pregnancy and the issues in labor and how to deal with them. But just know that that's a really big thing that needs to be looked at and considered. Car accidents come into play because if you see a car accident coming, that's when you have the most injuries from a car accident. If you don't know you're about to get hit, your body responds very fluid and the injury is much less. But when you see it coming, if you are the driver in particular, and you apply a significant force to one leg only into the car, and then simultaneously get a dramatic impact from the car into your body, that impact goes up the leg, into the pelvis, into the hip, and then translate it into the pelvis and low back, and is going to create a torsional force, even if there's not significant pain. Remember, pain is the signal that your brain gives us after a threshold. When it says that it can't deal with something, when it says that something's not working right, but it has a threshold. If we couldn't function with a certain amount of issues in the body, then we would all be walking around in constant pain and wouldn't be able to function. So the brain has this threshold of when it gives us those messages. So sometimes we can have this torsional issues, but the rest of the body's working pretty good. And so the brain doesn't deal with it. So if this type of injury has happened is what's important, not the injury that they got from that accident. Also in our history, previous pregnancy and birth history, everybody is asking these questions, I would expect. And so somebody who has pushed for really extended periods of time, somebody who had a really long drawn out birth, a baby that got stuck asynclitic, babies, sometimes a nuchal arm, babies kind of sometimes just do what they do also. But if they're really stuck in those positions and they've had to do really dramatic things to work through that in a really long drawn out process, or if labor just would cease because of it, they weren't able to progress because of it, those are all signs that there are other things going on. It's important to remember, just as Augustine mentioned in her little talk earlier, is that birth works. So the pelvis is designed to do this. The vast majority of the time, it still works. However, the point is, how efficient is it? Okay. It's about how much trauma do women have to go through unnecessarily with things that could have been taken care of. Extended sitting on a daily basis also increases some of this tension patterns. It really shortens the front of the body and really weakens the back of the body. So people who have a desk job, students, people who really sit a lot or just have sedentary lifestyles, this is going to be an issue and create imbalance in the pelvis. And then sports during childhood and puberty in particular. Any type of athletics and traumas are going to impact the body, but in my experience, these types of traumas and tension patterns, repetitive stress, the overdevelopment of certain muscles over other muscles that happens in childhood and puberty has a much more dramatic effect on the long-standing function of the body than it does later on in life. Recreational, here and there for just being active, less so. The really competitive, this is a big thing in the United States. I'm not certain how prevalent this is in India, but this is a really significant thing that's growing in the United States of becoming more and more competitive in athletics and specialized athletics at a younger age. And I'm seeing more and more issues because of that. This is always my number one clue that this person's going to need more care. And I myself, having been an elite athlete, I can verify all of the things that has to be done and how much retraining has to be done on top of restoring. And so this should be a number one red flag for everybody. All of those first ones really should show up in an initial visit history. The next ones are the things that we want to be visiting at every single prenatal visit. Where is their baby moving? This is one that's often ignored as well. A baby should not be restricted in the abdomen. If we ask a mother where she's feeling her baby move, and it's always in one spot her entire pregnancy or the majority of her pregnancy, this is a really big red flag. Her baby is restricted in there, which means that there is torsional stress in the body and tension patterns that are keeping that baby from moving around. A baby should want to move around the uterus early on in pregnancy. Really, they don't settle down. In my practice, what I see is they start settling down into a more specific and consistent position around 32 to 34 weeks, depending on how much room is in mom's body. And then obviously pain. If they start bringing up pain, that should be an indicator of, oh, something's not working right. We're going to talk about what things you can do to help support them in that situation. And then, of course, I've given you all of the reasons why, hopefully, you want to encourage some body work for restoration of their function. Now we're going to get into some things that you can assess for function because you are capable of doing some things also. And the first thing is teaching your clients how to stand. On the left, you see what a really typical kind of resting position looks like. And I apologize, these green lines are supposed to be helpful to see, but it was the brightest color that I could put on there that you could see. It's still not very easy to detect here. But starting at the hip, what we want to see is that in this person on the left, you can see that the hip, if we drop a plumb line down from the center of the hip, it's at the front of the ankle or in the middle of the foot. Now, what I can tell you is that as a chiropractor and working with lots of other body workers, this has often been considered normal or even ideal posture, that the pelvis be held over the middle of the foot. And I am going to very vehemently say it is not accurate. And if we had more time, I'd go into the whys, but really it's because, again, the models have been developed according to the male body and not the female body. And the pelvic posture is a little bit different in how dramatic it can move. And so we see bigger problems when it's not lined up properly. So in this first one, again, we see that plumb line in the middle of the foot. Her pelvis is leaning towards the middle of her foot. You can see her chest is leaning backwards, which is forcing her head quite far forward. Everybody likes to say, I carry my tension in my shoulders. And almost everybody says this, and that's because everybody carries their head forward, and it's not where our head is supposed to be carried. That is forcing shortening of the muscles in the front and lengthening of the muscles in the back and constant guarding of those muscles holding the head in a forward posture. So of course you carry your tension there because you're creating tension there all day long. But I want you to take a look at her low back. You see how her chest is leaning backwards, and that emphasizes the low back curve that we talk about. And we often say, well, this is just a normal change in pregnancy. And it's not. It's how we're choosing to stand. When she is leaning back like that, she's putting strain on the ligaments of the pelvis, because when she's leaning back and curved forward in her pelvis, the muscles are actually not supporting her properly. She's just resting in that position. Her rib cage, also the top of that green line in the front, the top of it is at the angle of the rib, and it goes down to the ASIS, the bone that sticks out on the side of your pelvis, and then down to the pubic bone. You can't really see the distortion very well in this picture, but what it's showing is that the pubic bone is a little bit in front, the ribs are lifted up, and that's part of her leaning backwards. So she's stretching her abdomen. She's relaxed in the low back and leaning on all of her ligaments. She's going to be tight in the quadriceps because she's holding her body forward and the back of her body is not supporting her, so the front has to. And then she's creating all this tension in her neck. When we look at the picture on the right, this is neutral posture. The side of the hip goes directly down over the heel and the lateral malleolus, which is the ankle bone on the side of the ankle. This is where we want to see the pelvis lined up. Then we want to line up the angle of the rib over the ASIS and the pubic bone. Those should be all in one line. This allows, you can see she looks dramatically taller. You can see that with her rib cage straight, now her glute muscles are engaged, her low back muscles are engaged. These are really large muscles that are supposed to be supporting us in an upright position. And now when we're in neutral posture, they can do so. Also, you can see that the abdominal muscles are not going to be stretched. They're going to be in an active position, not contracted and guarding, but in an engaged position where they can contract when they need to react to a force. One more difference in this posture that's really important for us to know: when the pelvis is tucked forward and leaning forward, and the body is leaning backwards, so the upper body is leaning backwards, think about what is happening inside of the pelvis. The reality is we're tucking the pelvis forward and bringing the coccyx closer to the pubic bone, which is shortening the pelvic floor muscles. This should be a ding, ding, ding when it comes to that rigid pelvic floor muscles. Why do women have such tight pelvic floor muscles? And why do we need to help to teach them how to relax it? If the pelvis is being held forward and tucked under so that we can relax our chest backwards and lift up, then we're going to be shortening those pelvic floor muscles. And now we're going to have pulling on the pubic symphysis, pulling on the coccyx, and pelvic floor muscles that aren't responding properly. They're not able to respond to a force properly, to increase pressures properly, and they're going to be more rigid. This becomes equally important in how we're talking to our parents postpartum. It's really common as we are taking care of infants that we want to create a shelf with our chest. And that's because our arms get tired. They grow really fast. And so we lean back even further. That poor posture positioning in pregnancy gets worse postpartum. So now look at the neck is even far forward in relation to the rib cage. The abdominals are stretched even more forward as the ribs are popped forward to be able to create that shelf. This is stretching the abdomen even more, which is going to prevent the diastasis recti from healing properly. And then on this, for this particular person, her hips are actually over her ankles pretty well because she's leaning so far back. Her pelvis has to be centered over her heels. But what you can't see very well because of these lines is that her pubic bone is quite far forward. At the same time, she's tucking in order to hold that tight position and hold herself backwards like that. You see on the right, if we teach people how to hold their babies in front of us and use their arms while maintaining proper positioning, their pelvis is in a strong position with the glutes supporting them well. Their abdomen is in an active position so that their core is holding them upright, and their head is much more directly over their shoulders and rib cage, which is going to decrease a lot of the tension and allow for a lot more postpartum healing with the pelvic floor and the diastasis, as well as decrease the amount of pain they have. Again, look at this picture on the left. She's resting on all the ligaments on the back of her pelvis and straining all of the muscles. As children grow, we start popping our hips out and putting them there on our hips. So when they're older infants or when they're toddlers, the bigger the baby, the further your hip goes out. And eventually your rib cage actually starts rotating also to give them room. If you look at the picture on the left again, you can see that all of her weight is distributed over her left leg. Her right side really isn't doing much. But because of the position she's in, she's not actually using her muscles. She's resting all of that weight on her ligaments. So all of those muscles, if you can kind of picture those muscles of the back again, all of the muscles on that left side are going to be shortened and guarded, supporting her while she's resting all of this weight. And then the other side isn't going to be checking in and doing its job. So imagine how much distortion this is happening here. And then imagine, what does that mean for the function of the pelvic floor? One side is going to, again, be tight and hypertonic and rigid because it's guarding. And then the other side is most likely just not even responding well. We want to encourage people to bring their babies up central to their body and up high on their body. We can then use our muscles to support ourselves in a proper posture that then supports good function, decreased pain, increased function, and increased healing postpartum and as mothers. So often people will think, well, I had my 6 weeks, I'm now healed. And then they go on and do all of this. I know that in India, it's a lot more traditional to have that 40-day lie-in, which is so wonderful that we do not have in the United States. But if we go and allow all this healing to happen in the first 6 weeks, and then we get up and we immediately start stressing our body and all these poor biomechanics, we're going to go backwards. And that's why we're not going to get that completed healing. So here's an idea that I like to tell people is that during pregnancy, another myth, you don't have to get weak just because you got pregnant. Pregnancy actually gives us an opportunity to get stronger. It is true that we get dramatic weight changes and we get distribution in our weight changes, and our muscles and our ligaments are changing to some degree because of orientation, because of the growing uterus, and because of the process that it undergoes during childbirth process. However, if we think about it, if we're gaining weight, that means our body is supposed to be working harder to carry that weight. If we're using posture that allows our muscles to actually work, they get stronger as our weight increases, as we have to further balance that. This is why it's really important to not only address this in the beginning, to teach people how to stand in a really strong position, how to hold their body, hold their babies, all of that in a strong position. But it's also really important to check back in that third trimester, because that's when that weight distribution has kind of suddenly become more dramatic. And often we need to consciously check back in and help them remember where neutral is. Remember how to use your pelvic muscles, your low back muscles to support you in a good position so that we don't put more and more strain on different areas, weakening the abdomen further than necessary, putting more strain on the pelvic posterior muscles and ligaments, which is what causes so much pain. As well as, this is the most important time to be encouraging good positioning for baby to be lined up for delivery. And so the more distortion in our daily habits and posture, the more likely baby's going to hang out really far over in a pendulous belly. They're more likely to enter the pelvis asynclitic. They're more likely to be turned around and just in all different positions that are not functional for an efficient birth. The big takeaway is that all of these changes are going to happen in pregnancy. That's a guarantee to some degree. It can vary considerably from person to person, but it doesn't have to correlate with weakness and dysfunction. Okay, poor body mechanics is the #1 cause, and midwives are just as capable of teaching people this. So here's a couple of examples of the differences that I'm seeing in my practice since I started really teaching posture. Pubic symphysis discomfort is a common thing in pregnancy. Often they have all different names for it, and everybody kind of just says, well, it's because it's loose and it's unstable, and so you're just going to have pain there in pregnancy. You're just one of those people. That's what you have to deal with. In the first half of my pregnancy, I would say that I adjusted the pubic symphysis on almost 60% of my patients. Not every single time, but at least here and there, and then a decent percent pretty regularly. In the second half of my practice, when I started really focusing on posture and teaching it on day one, it dropped down to less than 10%. Just by teaching people how to hold their body daily, decreased all of that pulling on their pubic symphysis and protection that's happening in the pelvic floor muscles that's pulling on it on a regular basis, as well as shifting their weight from being forward and their quadriceps pulling on everything and taking away the function of their abdominal muscles. So correcting it got rid of literally at least 50% of the people who had pubic symphysis pain. And that 10% that's left that I actually work on, I rarely do it more than once or twice. The very, very small percentage that I work on regularly are people who generally have very weak connective tissue and have had many babies already. That's where the level of dysfunction and weakness actually does require a lot more support. Another area is in diastasis recti. This was a really great thing to see. I worked with recovering from diastasis recti with a lot of my clients for quite a while for postpartum in the first half of my practice. And in my second half, when I started correcting people's posture and really focusing on that, I suddenly didn't have to do nearly as much. It was really common for me in the first half to see people who've had numerous babies have a diastasis of 4 to 6 centimeters at 4 to 6 weeks postpartum. And now it's most common for me to see 1 to 3 centimeters at 4 to 6 weeks postpartum. And it's important to note that 3 centimeters is really that cutoff of when those muscles can actually still function well. Beyond that, they're really in an upright position. They're distorted so much in their orientation that they really don't contract properly. So it really requires a lot more concentrated rehabilitation to heal that. But as you hopefully are putting together, if their posture and their biomechanics is staying poor, that healing is not going to be complete. It's not going to be permanent. We often do this really intensive programs to try to heal it. And then we go back to our normal daily life and stop those programs. And then they slowly open up further. And that's because our biomechanics is causing it in the first place. And so I have actually seen clients start their pregnancy with a larger diastasis than when they finish their pregnancy. So this is that reminder, pregnancy is still an opportunity to actually get stronger, not automatically weaker. Okay. This, of course, could be an entire lecture in and of itself, so I'm only going to be able to touch on it. But one of the points is to get us thinking about function and how much it's impacting people without kind of us addressing it. So some signs of dysfunction in labor that we want to recognize quickly and address quickly is going to be pain. And I'm not talking about labor pains. I'm not talking about normal contraction pains or cervix dilation discomfort. I'm talking about sharp pain, particularly at the lumbosacral joint over one specific hip. It's not usually both. It's going to be one or the other, or over the pubic symphysis. This is a sign that baby is not in a good position, that mom's body is not allowing baby to enter the pelvis well, and needs to be addressed really early on. If you address it early on in labor, when you see this, and get a baby into a better position, which again, hopefully in some other time you'll have the opportunity to hear me speak, and I can go into all of this in detail of the things that we can do beyond what I'm certain you already know. When we address that really early on, we avoid babies getting really stuck in asynclitic positions, or often even decrease our rate of shoulder dystocias because they're entering a pelvis better. If we let babies get into the pelvis and get really stuck in less than ideal positions, it's so much more work, and there's a lot more suffering on mom to get them out of that position and moving through the pelvis. Correcting it early, because we see that sign of dysfunction before we have a really stuck baby, is where we can increase that efficiency and help everything avoid trauma. Irregular contraction patterns, particularly in relation to the stage of labor or dilation or dilation and station that we are able to assess. This tells us the uterus is not getting good feedback, which is almost always a guarantee that a baby is not in a good position. Mom's body is not functionally working well. And if we can address this early on, we usually get one of two things to happen. Either it slows down because they're not actually in labor. They were doing prodromal labor, and their uterus was just being irritated over and over. And once we correct that, it just calms down and they go to sleep. Or the contractions start becoming actually functional and helpful. So they become in a more regular pattern, they have more tone to them, and they're able to actually help move through labor at a better rate instead of stuck in this really irritable, irregular contraction pattern that's just kind of wearing mom out without actually getting us anywhere efficiently. And then pain level relative to the contraction pattern. If we have a mom who's 1 or 2 centimeters and contracting every 5 minutes and she's in excruciating pain in her low back, we know that something is not right. Okay, so we don't want to just go, well, you're just in early labor, just rest, try to get yourself in comfortable positions and rest. That's not helpful. We need to change something. So all of these things are the early warning signs that you're going to have more things to deal with later on in labor and a longer, slower labor. If you can address them early in non-invasive ways, then you don't have to do as drawn out, traumatic, invasive procedures later on to get babies shifted when they're deep into the pelvis. In labor care, as I said earlier on, when I was a chiropractor, prior to becoming a midwife, I would get called to births from time to time. A body worker who's well-versed in working with pregnancy and pregnant body may be willing to come and address things in labor. I, as a chiropractor, would do adjusting and myofascial releasing, sometimes inversions. And as a midwife now, I will do internal soft tissue work if necessary to get the balance to allow the baby to shift into a better position. And then doulas, midwives, anybody trained can also do rebozo, positional changes, spinning babies. These all work for the same purpose. It's about creating more balance, allowing baby to shift into better positions, allowing mom's body to relax and allow changes to happen. When you have a body worker that's well versed in it, we just get to be more specific. And so we make those changes a little faster. So that's part of a little bonus if you can get a team together to support you in your practice and the clients in your practice. But there are a lot of things that we can do as midwives as well. Again, saved for another class. My dirty little secret is that even though I'm a chiropractor, I almost never adjust in labor. And that's because I don't have to. If I've taken care of everything leading up, I just don't have the need to do any of that work. It's really rare for me to do rebozo, spinning babies type stuff or doing any adjusting. And when I do, it's those times when a baby is really wrapped up in a cord and with a funky nuchal arm that's stuck in a way that we really have to work at every stage to get baby shifting through those cardinal movements and get them through the pelvis. Otherwise, I just don't have to do it. Babies just aren't in those positions. Or even if they start labor, it's really common for babies to start labor in an ROP or LOP position. I don't stress out about this at all because most of the time in my practice, I know if this is where baby is, it's almost always because there's an anterior placenta and they have to get into the pelvis a little bit before there's room to move anterior. And they do. Once labor happens, they do that because they're not stuck in that position. They just have to be there for a moment until they can move with the natural changes that labor happens. And so I don't have to do these things in my practice, but it's when I'm covering for other midwives, it's when I'm called to come and help is when I'm doing all of the things, because now I'm trying to restore function. I'm trying to back a baby out. I'm trying to move them into a better position, get mom's body to relax and become balanced so that then we can move forward again. If we take care of them in pregnancy by offering our referrals, give them the options to be proactive about their care, but also in our own recommendations about how they use and hold their body, then we just avoid a lot of it in the first place. So the goals, I hope through this conversation that you can see that women don't need to suffer, that it's the vast majority of the time, most of these things, most of these complaints and issues that women experience are because of signs of dysfunction. And if we address them well, if we get them the care that they need, they get treated and they can then go on to experience their pregnancies so much happier and so much more positive and set up for their childbirth process in such a better way. Daily habits contribute a significant amount to pregnancy symptoms and to difficult births. And those are things that you can counsel your clients on yourself as midwives. And then there are other providers that are supportive, that offer supportive, specific functional care. Collaborating with them can only benefit you and your clients. It's also true that we have to do a lot more work when the births are difficult. It's hard on us as well. So this is twofold. Our clients are happier and they feel better and they have better outcomes. And we experience less trauma and stress in the difficulties of our job. I do understand that chiropractic is a growing field in India. It does exist, but it might not be in every area. Interestingly, my chiropractic school that I graduated from is actually one of the big starters here in India. And they have kind of yearly or bi-yearly mission trips and help come and train and have sent numerous chiropractors here to practice. So I know that it's growing. If you don't have chiropractors in your area, then it's a matter of where can you start? Who do you have? There's other types of body work and it might not address things quite as specifically. I think the research does show that. However, it's still anything that helps create more balance with your clients is going to have positive effects. So obviously your physical therapists are a great resource, massage therapists, even yoga therapists, particularly if they have specific female-oriented specialty, skills specifically for females, or ideally even pregnancy, they're going to be of assistance. So find who you have, start there. And I hope you just understand that a balanced pelvis facilitates an easier birth. Remember that humanistic care is about the human experience, okay? It is about our job in providing it is about providing informed decision-making and choices. It's providing information so that patients can actually take information and understand more about themselves and understand the process of what's going on and what they can do for themselves to make it better. And then, of course, it's recognizing a greater need for further assistance and referring and making recommendations that are appropriate. Supportive care equals happier clients. It's all too often in my practice that women at 37 weeks have seen me 3 times and feel better than they did at 20 weeks. And they're ecstatic. People cry in my office all of the time, but they're also simultaneously really frustrated because then they say, why didn't anybody tell me to do this sooner? Why did I have to go through 4 months and then my baby gets stuck in a bad position before I was referred to you, when clearly I could have been feeling better this entire time and avoided it in the first place? So this is part of that job. It's about understanding, recognizing what's going on, start with what you can do, and then recognize when you need to make recommendations for further things. Learn who's in your area, how can they better support people. And I hope that gives you some hope that there's a lot that can be done and that birth really doesn't always have to be as difficult that it is. There are no guarantees, of course. In that 4.5% of cesarean rate in my practice and that 6% transfer, they had cruddy circumstances. They had really difficult things that we were not able to avoid because there are some things that just happen in birth and we have to deal with them. But so many of them can be prevented and assisted. Thank you for this time. I really appreciate this opportunity and I hope it's been helpful. I do have some references for you if you're interested in more information and understanding that neurology and physiology. And otherwise, if we have any questions.
Oh my gosh, Joella. I think this was amazing. As midwives, we are always, trying to find tools to work with physiology, to enable physiology, to facilitate it. And this shifts a lot of things for us as midwives, I'm sure. And I would like to say for the rest of the audience that in case you're interested in learning more about Joella's work, you can please log into midwiferywisdom.com website and watch out for new courses that we will be launching later this year. All right, so I just want to say before questions start coming in that the statistics that you presented about your vaginal birth rates, that's pretty mind-blowing and very, very impressive, I should say. The VBAC rate of 90% is also amazing. Thank you so much. It was lovely listening to your presentation.
Thank you.
Are there any techniques that can shift a woman from a sympathetic state to parasympathetic state in labor?
So her question was with respect to shifting the states, the neurological states from parasympathetic to sympathetic.
Sympathetic to parasympathetic.
Yeah, so there's a lot of different reasons why a woman's going to be in a sympathetic state, but from a bodywork standpoint, where is she holding that tension? And so sympathetic areas, of course, are through the middle of the body. When the upper cervical and the pelvic area is balanced really well and working well, that's going to fire those parasympathetics more. So sometimes it's a matter of getting them out of their head and out of that fear spot, but then encouraging that focus and stimulation to those areas and allowing and helping them relax, which can be through movement, it can be through body work, it can be through positional changes. When they can relax that area and stimulate changes through there, then that's going to help fire their parasympathetics a lot easier.
Most commonly what I have found is like relaxing their jaw or massage process, gentle massages and a bit of like relaxing their thorax also help. But are there any other points that can, make that difference? I only know these 2 points, but many of the times here, we don't get a chance to attend them prenatally, and sometimes they call us like during the labor. So what can we do? I mean, what are other points that we can work out? In your experience, like what are the common points that they are storing there? I just take up these points because they are like easy way to approach vagus nerve. Are there any other points that
Yeah. So what I would say is the jaw is fantastic. It's a great place to go to get women to relax and get into that parathenic state more. And the jaw is so tightly correlated with the upper neck, which is where all that neurology really is. And so on top of that, when the jaw is really tight, they're holding their tongue really tight. That's affecting the nerves coming through their skull. So releasing that is a really great way to encourage that. When it comes to the pelvis, it's really more about what's the relationship between the baby and the pelvis. The combination of the two is usually what's aggravating, irritating, and not allowing that relaxation to happen. And so when I would attend as a chiropractor, it would be kind of gathering that information of where is mom feeling her discomfort. When there's pain over her pubic bone, pain at her hip, pain at her sharp pain at her lumbosacral joint, it's almost always that an arm is in a funny position, almost always. And so that's when we kind of back the baby out of the pelvis. So it's not even so much directing care towards where it hurts, it's actually alleviating what's causing it in the first place. So it's backing the baby out of the pelvis if it's safe to do, given the situation of station and membrane rupture, so that then we can encourage different movement and baby shifts and enters differently. And that actually allows it to relax. Part of why muscles aren't relaxing is because there's actually not good feedback happening to those muscles. And that can happen because of joint dysfunction or also because of baby misalignment. And so what's fascinating and why I think spinning babies and positional changes and everything makes a big difference is that in childbirth, the baby actually provides the opportunity to give mom stimulation. So the baby forcing pressure onto those muscles and forcing them to stretch actually sends those signals to the brain to tell them to relax further. And so when we're doing all these positional changes and encouraging movement, that baby puts pressure in different areas, we then get feedback to those muscles to relax and allow baby to move in. It's just more efficient if we can get balance happening. And so when I am assessing, first I'm going to see, do we need to back the baby out? Is baby stuck in there? And we need to give baby room to shift themselves. And then I'm going to be assessing movement of the sacrum. For the most part, I'm doing myofascial releasing. So I am assessing kind of where is that counter pressure happening? Where is tension really kind of holding restriction and usually kind of a torsional force? And I'm working with that and releasing that directly. It's really hard for me to be able to explain. That would have to be kind of a live workshop thing in feeling, but we're really trying to feel where is the tension of that myofascial and can we work with it? I don't do, even if I do adjusting in labor, I don't do typical gross manipulation of joints in labor. I'm doing more pulsed. So I'm going to hold those tension patterns and I'm going to follow that tension pattern with a vibration or pulsed kind of force and follow it down literally from the joint all the way down the fascia or the muscle that it's attached to. And usually we're going to follow down towards the coccyx or we're going to follow down towards the hip because that's where the guarding is. That's not releasing. And so I'll work with that. And that usually the combination of baby shifting, the tension releasing and mom relaxing all starts making those kind of magical changes and we start getting change happening in a baby engaging again. I hope that's helpful. I feel like that's kind of the best I can do in this type of a conference.
Yeah, that was informative. Thank you.
Absolutely. Thank you for asking.
Anyone else with any questions for Joella?
Thanks for such an informative presentation. You know, we're always looking for resources to use with lower income populations.
Yeah.
It's where we do most of our work. And this involves, you know, direct workshops and training with women from these communities, as well as kind of NGO staff who many of them are from similar kinds of communities, maybe a few socioeconomic levels up, but, you know, not very far removed, who work with these communities and visit them very regularly. So again, some kind of, you know, a simple resource. This is what you can do without getting a full assessment, which they, you know, there's no way they're going to have access to chiropractors and, you know, any of this type of thing. That would be great. Really useful. Thank you so much.
Yeah, absolutely. And one thing, I wish I had thought about it sooner, but one thing I will do my best is to try to get a hold of my chiropractic school to figure out where they have kind of locations set up where they visit and different things, because there are opportunities where it is free, and there are things, and I know they most likely have a directory of chiropractors in the area. And sometimes, especially with a specific population, sometimes there are chiropractors that are happy to donate some type of care for different circumstances and things. So I will do my best to try to get a hold of them and get as much information as possible, and I will pass that on. This is also why I really wanted to teach the whole postural and biomechanical aspect, because anybody can teach that, and it really does make a dramatic difference. It's hard for me to assess, what is making how much change for each person given the circumstances, because I always do all of it. So I'm always addressing specifically with adjusting and doing the postural. But I had great results before I started doing posture, and to now see the tremendous results after it, I can confidently say just even giving that information and helping people use their body better really does make a big difference. And if they haven't had significant traumas, if they haven't been, really high athletes, if they haven't had things that really say like we're going to have longer standing and deeper issues, it's going to make even more change simply by teaching them how to hold their body better. So I just really encourage kind of thinking about that and incorporating that into your visits here and there throughout the pregnancy. And I hope that helps a little bit, because it is sometimes one person is the only person that they get to see, and we just have to do the best we can. And so the most that we can do is what we can do, and then find other people when we have the opportunity. But I will do my absolute best to try to get as many resources for you as possible.
Great, thank you. And I take your point well. And we do some of that already. We do incorporate a little bit of that more from physical therapists who we have in our team. We actually don't have any chiropractors in our team, but it's really what you have to start with. And, we're also some of the information that we're using to work with these populations, or we're working with other groups to kind of get them on platforms they're going to have much wider dissemination. So just some very simple techniques that women can do themselves and understand that would be great for us.
Yeah, absolutely.
Thank you so much.
We're looking forward to your next sessions, Joella. Thank you so much.